Ministry of Health, Kenya, working under the Directorate of Healthcare Financing. Oh. I don't touch. Oh, there we go. I'll briefly be looking at this outline as I go through my presentation. I'll look at the UHC overview in Kenya, what has informed us, make decisions, the decisions we are currently working on and continue working on. What are the challenges we've experienced and continue experiencing, and maybe some of the solutions to those challenges in achieving UHC? What are the lessons learned in health financing for UHC in my country? And what are the current reforms that Kenya is undergoing as we move forward through the journey of UHC? So Kenya, like any other country, has a collective aspiration to have access to quality care of health services for its countrymen without suffering financial hardships. And Kenya had to look at these 4 A's. They needed to answer these questions, guided by these 4 A's. How are we going to have an affordable services? That's in terms of financial protection. How are we going to have accessible services in terms of equity? Are we going to have available services across board for every Kenyan? And how are the services going to be acceptable in terms of quality and safety? Our approach is high quality, people-centered, integrated interventions. I know this box is all familiar, but it assisted us as a country try to answer some of the issues that we are currently addressing. For example, who is covered in our insurance and who is not covered? What's the extent of the coverage that we currently have? What are the services covered and what is left out? And what do people have to pay out of pocket? And how are we going to reduce this out-of-pocket expenditure, which currently stands at 24% in Kenya, and we aim at reducing this by 14% in 2030. So when we looked at the insurance coverage, under the Kenya Demographic Health Survey of 2022, we found out that 1 in 4 persons in Kenya, that's 26% of females and 27% of males, have some form of insurance. Currently, the National Health Insurance Fund coverage was at 24% for both male and female. Urban insurance coverage was at 39% for females and 41% for males. Rural insurance coverage was at 20% for females and 19% for males. We also determined that wealth determines insurance coverage, like my colleague Barasa said in the morning, that 5% for both male and female were at the lower quintile, with 56% of female and 60% of male in the higher wealth quintile. So wealth determines insurance coverage. We were also guided as a country by these UHC critical drivers, population coverage. I don't want to go through this. I know most of us know this. Access to quality services and financial protection. As a country, we took the route of primary health care. We all know that primary health care is essential health care made universally accessible to individuals and acceptable to them through full participation at a cost they can afford. So our approach in primary healthcare is through the communities, community networks, which are linked to the community units, linking to the levels or the spokes. That's the level 2 and level 3 in the health facilities. Those are dispensaries and health centers. We also linking through multi-sector approach, partner involvement, both at county. In Kenya, we have counties. Those are the smaller governments. And we also have the national government. That's the national level. Also, linkages with working with other ministries, the Ministry of Water. That's sanitation and hygiene, education through talks, health talks, and agriculture in terms of food security and nutrition in respect to UHC. This also guided us at the PHC commitment, which had a vision for primary healthcare in the 21st century, emphasizing on a comprehensive PHC approach by proposing 3 components. Those are the health in all policies, that's a multi-sectoral approach or action, empowering individuals, families and communities, and integrating the health services. So that is our model currently as we are looking at it through primary healthcare. We are having the community networks down there. Community networks are networks that are run by the community health promoters currently. The community health promoters are people that have been trained to identify or pick up red alerts for any diseases. And then they are supposed to report upwards to a community health assistant who is a trained health personnel who has either retired from the health profession or is or resigned for some reasons. And these are supposed to then guide how you refer the client to the upper levels in this linkage of the levels 2 and 3. That is dispensaries and health centers, all the way to the hub, which is the level 4 facilities for specialized care. So what are the challenges in achieving UHC? I think what we felt is that even as much as we are financed, even if you are financed, there are also issues that may derail us from achieving what we have set to achieve in UHC. And some of those issues were challenges with inadequate human resource for health, in terms of a lot of disruptions in terms of industrial strikes. Without the human resource, even though we are financed, we may not be able to achieve the UHC as set. So we are trying to address those issues. We are also recruiting community health promoters to assist with the linkage, like I talked earlier in my model, in the linkage from the community to the hub. So the country is in the process. We've already employed the first batch, and they've already been deployed to the various facilities. We also need to address other challenges like ineffective supply of health products and technologies and commodities. We know without that, we may not also be able to achieve what we intend to achieve. Health financing has also been an issue. We know that most governments, mine included, we've not been able to attain what we needed to attain in terms of health financing. But what are we doing as a country? We are aiming at increasing the number of households insurance under the Social Health Insurance Fund. This is a new bill that is in Parliament currently, having gone through the first reading, and we are hoping that it's going to pass. Bringing together all the indigents and if we look at the Social Health Insurance Fund, we are also focusing on primary health care, modeling targeting about 80% of the households. And households target of 5.2 million indigents, households paid by the national and county governments. We are also working with the provisions of the Public Finance Management Act to reinforce health insurance funds to allow retention and utilization of funds at facility level, the FIF bill. The FIF bill is also in Parliament, having also gone through the first reading, and we are hoping that our facilities will be given autonomy to utilize the funds that they collect for their use. So lack of integration was also a challenge. Integration of health information system. We know data is key. So we are working to increase and cater for the increasing data traffic, and we are hoping to improve on our systems for that. Primary healthcare, I already talked about that. Operation of 315 primary healthcare networks is already underway. The president already flagged off these community health providers, and they're already working. Community procurement of community health promoters kits, these are already done and given to the promoters, and also the rolling out of the community health information system, which is underway and work in progress. So what lessons we learned on health financing in assessing or in achieving UHC? We are basing our lessons on the priorities of UHC, and we are saying that each person can access health benefit package that addresses their needs, including those in hard-to-reach areas. And as we talk and we refer to our primary health care, we know this is possible with the community networks. We know that anybody now, we are not leaving anyone behind, everybody is reachable. All Kenyans should be protected from potential financial catastrophe arising from the use of health finances, or health services, sorry, special focus given to the poor and the vulnerable. We are also having a bill on the emergencies and the chronic diseases, which is also awaiting to pass, and we are hopeful that it's going to pass. Inadequacy of health resources for health services is key. We all know that without finances, we may not achieve what we intend to achieve. Political goodwill goes a long way. And we are happy at the moment as a country. Our president is in the forefront in these bills and even in achieving of the UHC. We know that he'll be launching the UHC this month on 20th during one of our public holidays. So this was just a slide to just show where we raise our funds from the national government, the county governments, now the social insurance fund, external funding, where we intend to get our funds, private NGOs, households, that's out of pocket. We know we cannot eliminate out of pockets completely, but we are working on that. Sources of funding, I know this one, Barasa had already brought it forward, but I think his was an African look. This is the Kenyan aspect. We can see the color down here, that's the government sources. We can see through the years, the government has tried to raise its expenditures on health. We are still not there, and we are hopeful that with the new government that we have, we are going to raise above this. The household out of pocket is still an issue. So what's the commitment of the government to deliver UHC? General taxation. Social health insurance fund is mandatory as we move forward. So the government wishes to raise funds through the social insurance fund and other taxes. Universal seamless health insurance, both publicly financed through mandatory prepayments. I think that one already talked about. National funds for chronic catastrophic illness, I already talked about this. This is a fund that's already in process. And we are hoping that it's going to really assist us Because once a client has exhausted the cover in the social health insurance fund, then they'll automatically be captured under the chronic health, the chronic catastrophic illness fund, which will be funded by the government. We've been having a lot of issues with clients, cancer clients, who exhaust everything that they were covered on, and they are not able to manage the illnesses. So they are left selling everything to cater for the condition.
And when you have exhausted everything, MTN will say, you have 1 minute remaining.
Sorry, I'll be very fast. So the current reforms, those are the last ones. What are we doing as a country? We are consolidating all the schemes within NHIF into one. I talked about the Social Insurance Fund, which is currently in Parliament. The Emergency and Chronic Diseases Fund, which is also in Parliament. We are restructuring the primary health care. We are also costing the health services. We have already so far done costing for level 2 and 3, that's dispensaries and health centers. Innovative financing mechanisms. We have already talked about the FIF. We are talking about ring-fencing funds and making facilities autonomous. This is just a slide to show we've also updated our essential benefit package to capture conditions that were not there initially: oncology, foreign treatment, emergency services, surgical services, cancers. So this is where we are going. We are coming from voluntary to compulsory. We are talking about prepaid and not out of pocket. And we are also focusing on domestic resource mobilization and not external funding. So what's the way forward? Our way forward is PHC, and also the Chronic Disease Fund, Social Insurance Health Fund, domestic financing, and also integrating of health services. And as a country, we are saying UHC is a journey, and we cannot leave anybody behind, private, public, that we all need to work together. Thank you.
Thank you very much. Madam, please stay with me for 2 minutes. And so we want to do this in a very simple way. 15 minutes for presentation, 5 minutes for engagement. Just 2 questions, comments, suggestions. Even if you have a prophecy, we'll take it. So please. Yes, ma'am, I see you. You have a mic on your table. Shoot straight to your comment, your question, your suggestion.
I'm hoping there'll be more of suggestions than questions.
Yeah, thank you very much for a very good presentation. And I really like Kenya's vision for the future. You mentioned that you're looking at mandatory
contributions.
Mr. Operator, what's wrong with the mic? You want to blame it on Israel and Hamas?
Yeah, my question is just very brief. You have a timeline to achieving this mandatory contribution or membership, and how do you plan to bring them on board, and how do you plan to keep them on board? We know we have this large informal sector in our economies, and even though we know that mandatory is the ideal, implementing it or enforcing it is a huge problem. So I just would like you to share with us the plans that you have to implement it. Like, how do you bring them on board? How do you keep them on board?
Let's take the last one.
Thank you very much for the presentation. Now, again, Dr. Francis from Nigeria. We know that UHC is a political journey, it's a political decision. And a few years ago, your former president, Uhuru Kenyatta, came out very strong on universal health coverage. I'm just curious, as a student of political economy, can you tell us what that big bank achieved in the health sector of Kenya?
That's a Section C question. Please.
I want to start with mandatory. Mandatory, like I said, the Social Health Insurance Fund is a mandatory bill that's currently in Parliament. I may not give the timelines now because it's still in Parliament. We've only gone through the first reading. We don't know when they're going to finalize on that. How are we going to keep them? Like Barasa said, doing it is one thing, and also trying to keep them is another thing. So it's work in progress. Yeah. The second question is very political. You asked, maybe he can come again.
Oh, okay. President Uhuru Kenyatta's Big Four agenda had health as one of the Big Four, right? And it started with a pilot implementation of UHC, which was actually tax funded. It was conditional cash transfers for that. So government implemented it. There was actually an evaluation. But within the implementation time, there was also set up a panel for the reform of the NHIF. The panel issued its report in 2019, and the panel's report is really the basis on which some bills have been tabled before Parliament in Kenya.
Thank you.
So you're asking why it has not moved since Uhuru Kenyatta. But I can say it was still on. It's only that we currently have a president that's very vocal on UHC. He keeps talking about UHC and financing. Uhuru Kenyatta started it, but it went a bit quiet because I think at some point it was a bit quiet. But we have a president who is very vocal in the issues of UHC and health financing at the moment. I think that's why now we are hearing more of it in the country.
The beautiful thing about this session is that right after this, we shall have a moment of networking so you can go into details of these. Please, a round of applause for Kenya. Coming up next, the land of 1,000 hills, I give to you Rwanda. "15 minutes for your presentation and 5 minutes to engage." Over to you.
Thank you. According to the agenda, I had prepared slides for 30 minutes. So if you see me skipping some of the slides, it's because of him, not me. This is what I'm going to cover. For us, we have, as the Rwanda Social Security Board, we have 2 health insurance schemes that we are managing, but the most interesting one is CBHI that most of the people know, that also has helped us to move towards universal coverage. But we also have another social health insurance that is covering mainly public servant and some private, as well as retired population, which is also something we need to discuss. I will not go through what Matthew has covered in the morning, so just to highlight that in Africa we are still lagging behind on coverage of essential services, and Rwanda is not excluded. I just picked a few neighbors to compare with in terms of financing from the World Bank data. Most of us are below the average that Matt was presenting of $200 per capita. Except our neighbor Kenya, who spends more than 200. All the others we are below. Rwanda is in orange. But with this financing that is not yet sufficient, when you look at the output, one of the things Rwanda has done well, I think, is on financial protection, where out-of-pocket has been reduced to the levels that usually you see in either countries that are spending a lot per capita, including, for example, South Africa. But when you compare with all the other neighbors, out-of-pocket is still high. And the blue and orange is depending on the 10% threshold or 25% threshold. So how did Rwanda reduce out-of-pocket? I think that will be covered in the next few slides. I can skip this. I think before we go into insurances, we wanted to present the findings of the recent public expenditure review by the World Bank that showed that the gray bar you see on the bottom is government expenditure that has been increasing, while the orange has been slowly reducing external funding. And surprisingly, with all the coverage that I'll be presenting in the next slides, the two schemes that we manage are only representing 13.3% of the total expenditure. So insurance is not the only way of financing. So government is spending a lot through input-based financing, such as salaries for the doctors, construction, whatever. So in terms of financing, the share of health insurance is still limited, is still low. But we expect to be increasing. Out-of-pocket is 10%. So these are the two insurance schemes that we manage. They are financed differently. One is, it was created as community-based insurance. That's why it kept the name. Although in the following slides, we realize that we have been losing that identification of community-based towards more social health insurance. And in the beginning, it was almost 100% funded by the members with some government subsidies. But you will see in the next slides that we have started new innovative financing that have reduced the proportion of financing from the members towards financing through some of the sources include subsidies from other public and private health insurance that are supporting the informal sector, and other earmarked resources that I will go through in the details. On contrary, on the social health insurance we manage, it's funded by employer and employee, mandatory for the government staff. Since now, they're also celebrating now 22 years since it was created. 7.5 from the employee and 7.5 from the employer. Mandatory for the public, but optional for the private sector. You will see the numbers on how private sector has been finding interest in our scheme. In terms of coverage, I think service package, we cover most of the same service package with some differences. Number one difference is strict referral for the community-based health insurance. We managed to keep 85% of utilization at primary health care because to go to the hospital, you need a referral note. If you step up to the referral and it's not an emergency, you will pay yourself at 100%. So that's how actually, that's how we survived. The two schemes have copay, which we are still now reflecting on how we can reduce copay. But for the community-based health insurance, it's a fixed fee of $0.16 for primary health care and 10% when you go up in the hospitals, while it is 15% across in the social insurance scheme. This is a slide that shows a story of now more than 20 years of rolling out this universal health coverage. We have had our high and lows, and one of the determinants of the reduction of coverage around 2012-13 was due to the change of contribution. We increased contribution per person and it dropped. And we are planning to do it again. It has been a long time since we have done it, so we expect another probably reduction. But we have been maintaining above 85%. And how do we calculate this? We first look at everyone. We remove those who have other insurance, and that is our 100%. So this is 90.1% of people without other insurance. Contribution-wise, not everyone pays the same amount of money. We have categorized household into 4 categories. from the poorest to the richest, and the poorest are covered for by the government. This is a system that is run by the community under the supervision of the Ministry of Social Affairs. And it's not meant for the health insurance only. It's meant for social protection. So they receive other services, including cash transfers. Those are the kind of services they receive. And we build the same categories around those. What I can say here is that we found this process not efficient at the moment. Now we are trying to make it more objective, more explicit, because most of the services have been digitalized by now, and it's all around one ID. So it will be more digitalization, linking all the services, including land, including tax, payroll, so that when you graduate from poverty, someone can see it and you will be upgraded immediately. Otherwise, it was more community gathering that decide this belongs to this category. You understand the amount of subjectivity that is involved in this. But starting with 17% covered for by the government, it was a very good ground for us to mobilize for the rest and the limited amount of money that you see there. And enrollment is by household. It's not individual, and it covers 1 year. But government has, we have established the way that you can contribute up to 75%, and you start enjoying the benefits for the first 6 months, after which you have to complete with your 25%. So you don't have to have all the contribution before starting enjoying the benefits. This is the story I was talking about. Recently, only 3 years ago, if you have heard about the community health insurance before 2020, you will not recognize this graph where the contribution from the members has been reducing. It is now, it was 38 in the year 21-22. The other slide I will show, it reduced again to 32%, down from 70%, only in 4 years. Why? Because we have a new system that have provided for much more source of income, including telecommunication, fuel, 20 francs per liter. Other insurances that are giving also 5% when you are private and 10% when it is a public insurance. So one of our insurances is contributing 10% of the premiums to the community-based insurance. And of course, government become also remaining the highest contributor after the premiums from the members. I think I've talked about this. Government has also increased from 2,000 to 3,000 per member of a vulnerable family. So that was one way of increasing a contribution to the scheme. I think you will share the presentation to see it's a list of 14 sources of revenues. Not all of them are performing. We still have 4 that have not yet started giving contribution because there was some administrative fine-tuning that we had to do. For some of the sources, structures had to change in order to accommodate what they will contribute, but it comes from salaries. It means if you are employed, your employer will enroll you to either public or private insurance, but in the end, your salary, 0.5% of your net salary will go to CBHI. You don't have to be a member. It's a contribution to CBHI, and it gives and telecommunication, fuel, other insurances, and so on. Traffic fines, motor vehicle inspection, 50%. This is the effect of those new sources. It was only, we almost tripled from 2018 contribution to now 2022. And the share of the members' contribution or premiums reduced from 70 to 32%. And that is the impact of the new sources. And the average revenue per member has doubled in only 4 years. The good thing is that all these new sources are based on consumption. So they are growing much faster than the premium themselves. That's why we are envisioning also reviewing the premium after more than 10 years without reviewing. So hopefully we cover more services as we go on. I think this is, the other social insurance is also growing very fast with a lot of appetite from it's mandatory for the public, but also private sector has been increasing. And both in membership and contributions. And the more it grows, with the 65 million USD collected by the social scheme, 10% of it goes to CBH, as I was saying. And this is the share between public, private, and retired population. Retired because Rwanda Social Security Board manages also pension, so we deduct 7.5% from the pension among the people who used to be in the scheme, and we keep them. Actually, there is a law since 2016 that was asking all the insurance to keep their population when they retire, but we are the only insurance that does it because it's very risky. Spending per person is more than 3 times the average spending on the other categories. So we are now discussing on how other insurances can actually have a contribution in the before, when people are still active, so that we cover them when they retire, because we are the payers as the Rwanda Social Security Board. And 80% comes from the public servant. If I discuss about success factors, I think they are the same with our colleagues in Ghana. Political commitment, government subsidies. I'm repeating most of the presentations in the morning, including Matt and other presenters. Community engagement. And the question on how do you make sure that more than 90% of the population, I think apart from political commitment, it's not at the high level, it's also up to the local levels. Every district mayor has always an indicator or performance indicator on having everyone among their constituencies covered. So they find their ways of bringing everyone in the communities, in saving schemes, engaging with them, saving small by small. We have seen a good trend that I probably will think about in the next in another presentation I make. Majority of the contribution come in the first 3 months. It used to be scattered across the year, but because people have been saving over time, when we open the system, we see a surge of contribution in the beginning of the fiscal year. Services are being more and more available. Primary healthcare facilities have doubled because of the new structure called Health Post. And that includes not only public sector, but also private sector. There is a model we crafted in Rwanda where a private owner can get a free facility from the local government, and we contract them when they start providing services. I think that has helped doubling the number of primary healthcare facilities. Having that system that categorizes people into socioeconomic categories that allow us to set premiums according to where they belong, I think it's also one of the success factors. Legal framework from 2016, it's mandatory to have an insurance in Rwanda. But enforcement is not easy. But we use it when we do mobilization. It doesn't prescribe which insurance you should belong to, but because majority are in the informal sector, they find CBHI, Community-Based Insurance, as the only insurance that has the open arms to receive them. Otherwise, private sector, they'll have their own restrictions, and other social insurance will also have their own restrictions. So having that law in place, I think, is also a success factor. And it's not, as I was saying, it's only 13% of the total spending on health. So you understand that there are other complementary payments, including performance-based financing and development partners as well. So we still have some challenges, increasing the coverage, also progress in financial protection. We are rethinking our co-pay structure to make it more affordable, but also expanding the services that are covered into the scheme. So primary and secondary, it's 100% of the services available, but tertiary, there are some selected services that are not yet covered by the scheme. So as more resources come, we go adding more services, and we have been doing it over time.
You would have a lot more challenges if you don't finish within my time.
Yes. So maybe I will make this the last. It was not the last, but I'll make it the last. I think other operational challenges we have are around the provider payment mechanism, which we are reforming soon, as well as the benefit package, the way benefit packages are structured. We have new legal framework that will push us to use HTA in defining benefit package. And next year in February, we are launching capitation. I think Nat was in Rwanda telling us the story of Ghana, and we have copied best lessons and put aside those that put it on hold. But we hope by February we have launched it, and DRG at the hospital level. I will make this my last slide. And I thank you for your patience.
Thank you very much. Please stay with me for a while. 2 questions, comments, suggestions. Yes, sir. There's a mic coming to you.
Yeah, thank you very much, and thanks for the wonderful presentation. In your presentation, you did mention that you have 3. Take it from there. Thank you very much.